Robert, would you like to introduce our guest speakers?
Yes, welcome everyone. Welcome to this discussion part of the IEC Symposium at the RADLA meeting. I assume that most of you, but probably not all of you, have seen all the presentations. So I think it would be interesting for all the panelists to introduce themselves. So I'm Robert Bissonnette. I'm a dermatologist based in Montreal, Canada, and I'm the current IEC president. Valeria, would you like to do this as well? But you're well known in Latin America.
Hello, I'm Valeria Oki from the University of São Paulo, Brazil, a professor of dermatology there. And I'd like to introduce Professor Amy Paller. Would you like to introduce yourself, please?
Hi, I'm Amy Paller, Professor and Chair of Dermatology and Professor of Pediatrics at Northwestern University Feinberg School of Medicine in Chicago, and a co-founder and first president of the IEC. Happy to be here.
Professor Ring, please.
My name is Johannes Ring from Munich, Germany. I'm Professor Emeritus at the Technical University in Munich.
Very good. So maybe we can start the discussion. I have a few questions, and I know that Valeria has a few questions as well. And my first one is in fact, a question for both Dr. Paller and Dr. Ring. We heard a lot over the past few years about prevention of atopic dermatitis. We know in clinical practice that some of our patients, of our infants, are at very high risk of developing atopic dermatitis and eventually asthma, rhinoconjunctivitis. A number of studies have been conducted looking at moisturizers with results that may not have been very convincing. What should we tell our patients? So the mothers and fathers who come in, the pregnant women, or the family that comes in with a young infant saying, I don't want my child, to have bad atopic dermatitis like I do. What can I do?
Well, I will tell you that I'm a bit disappointed by the large studies that recently came out that showed that there was no reduction in atopic dermatitis from application of daily moisturizers, and one even suggesting that there might be an increase in skin infections. I talk with the parents and I just tell them what's out there, that there's no evidence right now that doing that daily reduces the risk. However, I think if a child is dry, it's a good idea to get into the habit, especially after the bath, of moisturizing right away. And if a parent wants to do that, I don't think that there's any harm in it. But of course, we want to counsel to use moisturizers that don't have fragrance, that don't have a lot of plant-containing components that can be sensitizers. We want to just make sure at least that we're using good sense in what we're putting on a baby.
And maybe as a follow-up question for Professor Ring, you spoke extensively about colonization with S. aureus and the risks of infection. And we know that at least there are some studies suggesting that in infants, you start to be able to grow S. aureus on infants before they start to have visible atopic dermatitis. Do you think that from a preventive strategy, we could or should do something about this right now? First, in terms of research, and then in terms of practice. Should we try to eradicate these bacteria very early on?
The answer is no, and I will tell you why. Staph aureus and the atopic skin, this is a close connection, and we do not know exactly what is the hen and what is the egg. And when you culture dry skin in the atopics, you might find Staph aureus in 60 to 70% of the individual without eczema. So this is just a feature. And when you treat the eczema, the Staph aureus will be better. And when you treat the Staph aureus in the infected lesions, eczema will be better. But to eradicate on non-lesional skin or as a preventive measure, I would be very skeptical. I would not do that.
Thank you. Would my co-chair like to ask a few questions?
Yes, for Dr. Paller. Dr. Peller, in your experience using dupilumab, we know that there's solid evidence that there's the recovery of the expression of skin barrier proteins during the treatment. From the clinical standpoint, do you see the improvement of the dry skin in your patients?
I certainly do. Many of our patients don't even have to really use moisturizers. Others do, but are able to avoid topical corticosteroids. The skin certainly feels less dry. And in studies, it has been shown that the transepidermal water loss area under the curve can actually be reduced, not to normal, but certainly closer to the level of non-lesional skin. And that's really what we're going after. I think it would be interesting to look at whether those who have ichthyosis vulgaris, who have a primary reduction in filaggrin rather than having a secondary reduction because of the effect of the interleukin-4 and the interleukin-13, which, by the way, can also impact and lead to the reduction in tight junction proteins, whether there's a difference in terms of the improvement in the transepidermal water loss in those with primary filaggrin defects versus secondary.
Thank you. Robert,
just want to mention, just want to mention a comment that we presented at recently at the American Academy of Dermatology meeting, a study that was conducted in collaboration with Donald Young that was sponsored by Sanofi, where patients were, it was a 2-center study where patients were treated with dupilumab, and we looked at various aspects of the barrier, including transepidermal water loss. But what presented at AD was transepidermal water loss, and we found a very nice, rapid, important decrease in transepidermal water loss in lesional skin. However, and it goes exactly with what you just mentioned, in non-lesional skin, we did find that it was higher than a normal skin of healthy volunteers without atopic dermatitis at baseline. And when you look at the change over time, you see a slight non-statistically significant decrease. In the end, it is still numerically slightly higher than healthy volunteers. The difference is not statistically significant, but it didn't seem that we can completely renormalize. So it might depend on the patient. As you mentioned, maybe it's in patients where we have filaggrin mutations, it's more difficult. But in others, it might be more efficacious. More to come from that study.
Thank you, Robert. Now a question for Professor Ring. Professor Ring, there's been a lot of enthusiasm about studies regarding commensal bacteria topical treatments. What's your opinion about those studies?
Well, these are very exciting studies. It's a research area, and some studies look quite nice. Yet I think the evidence is not enough to really make a general recommendation. Let me compare the area with the commensals on the skin with the probiotics and prebiotics, which we are eating and drinking, and they are around for 30 years and are claimed to be helpful against atopy and preventive, but yet I think that we don't have a solid evidence for that. And there will be a long way with the skin, but I think it's exciting, and they don't seem to do harm. So it is, it's worth a try, maybe, yes.
I'd love to add to that just a warning about the need for larger studies and double-blind studies of these, agreeing with what Professor Ring just said. We had 2 wonderful articles, open label use of the Roseomonas mucosa that looked quite promising, but then the larger double-blind randomized trial came and showed that it was not effective. We've had very elegant in vitro and some early human experience with the Staphylococcus hominis A9 that looks quite promising in so many ways, but I'll hold any judgment until, again, we see the double-blind randomized trials that will help us to know whether this is truly effective versus the base.
It's exciting. Let's wait.
Thank you. Okay, Robert, you have the word again.
Very good. Maybe one last question to Dr. Poller. We recently have seen in the US the first approval of a topical JAK inhibitor for the treatment of atopic dermatitis. We have approval of systemic drugs. We know that there could be issues with some systemic JAK inhibitors in atopic dermatitis. Now it's very interesting to be able to have a topical one that can be used on smaller areas. What has been your experience so far? We've seen over the years sometimes products being in clinical trials with a certain safety profile, topical drugs specifically. When we start to use them in practice, we see things that are different from what has been reported in phase 3 studies. What has been your experience so far? I think the US is the only country where this has been approved. Is your experience in line with the phase 3 tolerability data that we've seen?
It just came out in the last few months, which means my experience is very limited. I'm not sure anyone's even come back yet into the office that I've given it to, but at least I haven't heard of any major problems. We don't have samples either, so we can't test it to see if someone finds it to be stinging or burning. But experience with the trials has suggested that it's well tolerated. I think it's going to be interesting to think about whether there are any issues in real life use. I know we were chatting before about viral infections, for example. We know with the systemic use that there can be an increased risk of having herpes zoster, some evidence perhaps of herpes simplex is increased as well. Will we have issues topically with an increased risk of herpetic infections of different types? Will we see other viral issues? We know in particular with children that biomarker analyses have shown a reduction in the type 1 immune markers. So children may be at even greater risk for having adverse responses to these particular viral organisms. So we'll have to get more experience and see whether this on the skin itself, even when we're keeping it under 20% body surface area and not really worrying about systemic absorption, can affect the cutaneous immune response to viruses.
Thank you very much. Obviously more to come. Very interesting to see all the new topical products that either have been approved recently or will be approved in the next few years because they've completed phase 3 or in phase 3. I think the way we treat our patients with atopic dermatitis topically will completely change in the next few years. So I want to thank the panelists and as well as all of you who attended, who watched this session. And if you have any questions about things that have been discussed today or things that have been presented at this symposium, don't hesitate. You can get in touch with the four of us. Thank you very much.
Thank you.
Bye. Bye-bye.